Dear colleagues, dear friends, it's a great pleasure to welcome you to this new EHAT podcast. Today, we will focus on a very important topic, which is surgery in patients with hemophilia having an inhibitors. Well, this is clearly a very complex situation, unusual situations in many centers, and it's clear that if you want to manage this successfully, you need a lot of expertise. So to help you in managing major surgery in patients with inhibitors, well, I have with me two colleagues and two friends with great expertise in this field. Maria Elisa Mancuso from Milan. Maria Elisa, welcome to you.
Thank you, Cedric. It's a pleasure to be here with you today.
And Yesim Dargaud from Lyon. Yesim, really happy to welcome you today for this new podcast.
Hi, Cedric. It's a pleasure to be here.
So before, really going into, what should we do, I think it's important to emphasize some very general principles that we should implement when managing or planning surgery in patients with an inhibitor. So maybe, Maria Elisa, you could start, what should we have in place?
So, what is important is to set up, if possible, a multidisciplinary team around the organization and planning, if possible, because sometimes surgery is not planned surgery, can be also an emergency situation. However, especially in these cases, it's important to have a team well collaborating one to each other, including, of course, the hematologist, but together with the hematologist, we need an experienced surgeon, anesthesiology, nurse, the pharmacist, because we need drug to manage this patient, and to have expertise on the management of inhibitors, because this can also be somehow relies more or less on clinical experience, because we have some problems, for instance, with the lab monitoring or so. So I think that the general principle is multidisciplinary team, expertise, and a comprehensive hemophilia treatment center to coordinate all the planned surgery and all the figures around the patient who need the surgery.
Yeah, that's what you nicely illustrate on your slides, the triad of organization, planning, and expertise. Yesim, is this your own experience in Lyon, in France?
Yeah, absolutely. I would like to check a recent inhibitor titer in these patients, because everything will be based, the choice of the molecules will be based on this. So we need to know if it is not a recent determination of the inhibitor titer, we should do it emergently. Yep.
Yeah, because today we would like to focus specifically on the management of patients who have an inhibitor. But as you say, it's important to check before any kind of invasive procedure whether the patient has an inhibitor that could have been ignored. So maybe, Yesim, what would be, in terms of specific management, before going into the details of the treatment, but in advance, more specifically for patients with inhibitors, what should be done in your view? What's critical?
Well, again, I think the coordination is something really important before going to an elective surgery. If it is not an emergency situation, we should talk not only to the surgeon and anesthesiologist, but the ward where patient will be hospitalized is also very important, because the molecules that we will use for hemostasis of this patient should be given really sharply on time. And sometimes nurses, they are not very familiar with these molecules, and we should go and, train them. Also, we should make sure that with the pharmacist that we have available stock of the molecule that we will use, not only for the surgery, but for the postoperative period. And if I move a bit more further, we should also talk to the rehabilitation department or the center, which can be out of the hospital, to make sure that patient can have access to the hemostasis treatment when he will be in the rehabilitation center, if it's an orthopedic surgery, of course. But we should really, think about the general environment and not focus only on the surgery.
Okay, thank you. So let's now move to the patient who have an inhibitor, who are not treated with the new agents that we have with the classical treatment. So how should we manage these patients who have an inhibitor who are candidate for surgery? So we are, just to make clear that this is not a patient on one of the new treatment like a non-replacement therapy. This is a patient who is treated, let's say, with classical bypassing agent who has an inhibitor. So how should we manage surgery in this patient?
So I think, basically those patients rely on the use of bypassing agents, so namely activated prothrombin complex concentrate and recombinant factor 7A. There is experience with both drugs. The main limitation is that in comparison, if we think about replacement therapy, in this case, we are not able really to measure exactly what we are providing in terms of coagulation activation. There are some tests like global assay that may guide us on the hemostatic potential, but unfortunately this can vary from individual to individual, so there is no standard protocol that fits all with those drugs. And in some cases, one patients have a better response to one agent rather than with the other, or vice versa. So if we want just to look at very simple differences between the two drugs, of course, we have to recognize that in terms of dosing regimen, we have a sort of capping dosing for APCC, because it's important not to overwhelm the limit of 200 units per kilo per day, given the potential prothrombotic risk related to overdosing of this drug. The volume of injection is rather high in comparison with recombinant 7A, and we know that we cannot give it very frequently. So the minimum interval for APCC is 6 hours, better to give every 8 to 12 hours. Again, because we cannot overwhelm the dosing, and also using a very low doses per injection may not be as effective as a regular dose of 80 to 90 units per kilo. Recombinant 7A has the major advantage of being recombinant, and so also this is related to lower volume of injection, but with the main drawback of having a very short half-life, and so the need for very frequent injection, sometimes even every 2-3 hours. And this, as Yesim already mentioned, may also complicate somehow the management in the ward, because the nurse should be like focusing on that single patients who should receive the drug very frequently. So I would say that bypassing agent management needs a lot of clinical expertise, also to judge the clinical efficacy, because we have no lab measurement that really gives us in a linear way, give back to us the efficacy of those drugs, and we need to rely on blood cell count, hemoglobin levels, and really look at the blood loss from surgical wound and the clinical situation of the patient.
Thank you. And well, clearly you nicely emphasized the difference between 7A and APCC, but is there, just to provide some guidance, is there any preference, or in any situation where you would preferably go for APCC or 7A?
I would say that, yeah, I would say that I would look would like to would give importance to the individual response of the patient first. So we know which patient respond better one to the other, and this is important. We may even appreciate the hemostatic potential through global assay. This is not doable everywhere, but thrombin generation assay can give us the idea of which is the hemostatic potential in single individual of either drug. There is, and for, let's say, high-risk surgery, maybe I would prefer as first-line recombinant 7A, because it's more manageable in terms of having the possibility to infuse it more frequently. So if we need to control a bleed, having the limitation of APCC being given every 6 to 8 hours in some situation can be not really ideal. But again, if the patient is a very good responder to APCC, this is also possible. So maybe Yesim can add something on that because she has extensive experience.
Oh, thank you very much. I fully agree with you, Maria Elisa. I would just like to say in a provocative way that if I have choice, I would prefer factor 8 or factor 9 if the inhibitor titer is below 5 beta unit per ml, because this is the only drug where we are sure about the efficacy and we can really achieve hemostasis. It's much more easier to manage this compared to bypassing agents, but I fully agree with you on everything you said.
Yeah, Yesim, but what you emphasize is very important. So clearly, if the title is low, there is an opportunity to use factor 8 or factor 9. So could you tell us a little bit more on, because our colleagues might not be fully aware on how to use this, especially when there is a significant residual title of this antibody, of these inhibitors?
Yeah.
With dosing of factor 8 or factor 9?
But this is why at the very beginning of our discussion, I said I would like to check the inhibitor titer of the patient, because if it's less than 5 beta unit per ml, then we can be able to neutralize, to saturate the inhibitor and use factor 8 or factor 9. And for this, we do not use, of course, the usual doses of factor 8 or factor 9, but much more higher doses. We should first to calculate on the basis of the patient's body volume and the inhibitor titer, the neutralizing dose of factor 8, and add to the top of this, the hemostatic dose that we need for surgery. So it's not a rule, but approximately it's 2 to 3 times higher than what we use in usual. So, but it should be individually calculated. And the advantage is it is always, the efficacy is guaranteed, which is different compared to bypassing agents.
And if I may add something, we have to remind that in the presence of low titer, despite having then the opportunity of, the possibility of an anamnestic response after 5 to 7 days, we can also use successfully continuous infusion of factor 8, factor 9, because having low titer, continuous infusion may be useful to maintain the efficacy for a bit longer than to give bolus injection. So it's also to maintain a steady state and not having a big fluctuation between peak and trough, related also to the kinetic of neutralization of the inhibitor. So I would say that yes, for factor 8, factor 9 in very high risk surgery, in patients with current low titer, to cover at least the first 5 days after surgery.
I fully agree with you. And there is maybe just a practical tip with the extended half-life factor 8 molecules. Now, the speed of the pumps that we use, earlier are not adapted, and we are using pediatric pumps. So you also need to talk about and organize it with your pharmacist before going to surgery if you choose for this option.
Well, thank you both for emphasizing again the important role of factor 8 in this context, because there is a lot of enthusiasm for bypassing agents and so on, but it's clear that many patients are eligible for factor 8. Yesim, maybe because in your center in Lyon, you have a long tradition of performing different global assays in these patients with inhibitors who undergo surgery. So maybe 1 or 2 key messages for our audience regarding the importance of this test?
Well, what I can tell you is we are using thrombin generation assay since more than 15 years now. And if you have access to this technology and also have a laboratory team, with the expertise on that, it can be really helpful. But what I can tell you now, we have not told about other therapeutic options, but it was really very useful to choose between APCC or recombinant 7A few years ago when there was no other options, because all drugs have been labeled with an efficacy of 80 to 85% in surgical situations. So there was still some space for patients who were not good responders to neither recombinant 7R or fiber. And it was really important to clarify this situation and choose a drug. But nowadays, I mean, almost all hemophilia A patients with inhibitors, they are receiving prophylaxis with emicizumab. And in my experience, even patients who were not very good responders to 7A, in combination with emicizumab, they do well. So, I mean, it's more interesting to my eyes today to check what is the efficacy of emicizumab alone, rather than to checking before surgery every drug separately. Because emicizumab already gives a certain level of hemostatic efficacy, and when you add any bypassing agents on the top, even in patients who were bad responders in time, now we achieve a certain limit of, I mean, a certain level of hemostatic efficacy, which is sufficient for a large majority of the surgeries, I mean.
Thank you. So thank you for this nice transition now. So what I would like to address with you is how to perform surgery in this huge number of patients with an inhibitor who are on emicizumab. So let's say we have a patient, he is on emicizumab, he has an inhibitor, this patient is doing well, and is candidate for major orthopedic surgery. So what are the key principles here? Maybe Maria Elisa, what should our colleagues know about this situation?
So first of all, that prophylaxis with emicizumab should not be paused or stopped. So those patients will continue with their prophylaxis, maintaining the steady state, knowing that, as already Yesim mentioned, they have an hemostatic potential which is now increased as compared with patients not using emicizumab. And on top of that, we know that recombinant 7A have not really an additive, maybe a bit additive, between additive and multiplicative effect on the hemostatic potential. So indeed, from also the real world experience that now that we are accumulating, is clear that we can use recombinant 7A and not really at lower doses, but rather at larger intervals than what we were used to do in the absence of emicizumab. So the surgery is successfully manageable with recombinant 7A given maybe at the very beginning every 3 hours, but then very rapidly de-escalated in terms of intervals to every 4, 6, 8, and 12 hours. There are some papers also summarizing these, let's say, new protocol, which have been successfully used to manage major surgery. So bearing in mind that on the background given by emicizumab is there, and this is really effective in improving the coagulation activation in these patients.
And maybe we could emphasize again the importance of checking whether this inhibitor is still there, because we have patients today who have been on emicizumab for a long time. They had an inhibitor, the inhibitor might have been cleared, and these patients could be retreated with factor VIII. Is that a scenario that you have already experienced yourself, Maria?
Of course, yes. Yeah. Of course, yes. This applies also on patients treated with EMI. What we already mentioned on the general rules of use of factor VIII, factor IX applies also in this scenario.
Maybe, Yesim, because we know that clearly there is a major interaction between APCC, FABA, and emicizumab. So what's the impact of this major interaction in patients who undergo surgery? Is APCC totally forbidden, or could we be a little bit more liberal? Any?
Well, I think that today the first step choice is recombinant 7A. We should combine a bypassing agent with emicizumab. But if there's a clinical, inefficacy, if the patient is still bleeding, then we do not have other choice than to switch to another bypassing agent, which is APCC. But I think the idea is not to give the usual dose of APCC, but to use lower doses. from my experiments, I can tell you that 50 units per kg is still very high, and it can be, I mean, it can induce hypercoagulability in some patients. I would try somewhere between 20 to 30 units per kg, depending on the importance of the bleeding. And if we cannot control with this low dose, then we can increase doses. But it is a critical situation, and we should be really very careful. And globally says if you have any in your hands, it can be helpful to assess the efficacy.
Yeah, and I also got the information that some colleagues in our community are re-exploring a little bit what's happening in patients on EMI receiving APCC, and maybe, we should have new data in the future because it could be a good approach in some patients. So we have other non-replacement therapy today. Some of them are even commercialized in some countries. So maybe, Maria Elisa, about concizumab, do we have some experience available regarding performing surgery in patients with concizumab concisely?
Yes, in the protocol of the clinical trial, mainly minor surgery were allowed per protocol. So we have some experience in minor surgery, few experience in major as per protocol, but of course we will have it in real world, which is still not really very extensive. And so far, so good. I mean that in patients treated with concizumab, surgery was done uneventfully. But the real important thing is that the doses of bypassing agents in combination with concizumab should have been remodulated in terms of dosing per infusion. And per protocol, this drug has been used only in combination with recombinant 7A. So I think we have no experience at all by now in combining concizumab with APCC.
And maybe, Yesim, any relevant data to share regarding surgery in patients on fitusiran? Fitusiran is these agents that reduce the liver production of antithrombin. So do we have some published or reported experience so far?
From the top of my head, I remember 7 surgeries reported in different congresses. Some of them, they are major surgeries, other only tooth extractions. We do not have the detail of the hemostatic management of the surgeries, but what we know is in a recent publication, the scientific committee of the Atlas and Atlas OLE program, they recommended really very low factor VIII and also bypassing agents combination when we use them with fitusiran. Just to give an idea, the recommended dose of factor VIII is about 10 units per kg. So it's not, we are very, very far along our usual doses. So we should be really careful with these patients. They are for the moment just in studies, but we need more experience in real life.
And another provocative question, because no new products are currently being developed, in particular, hyperactive, bispecific antibodies. Do you think it could be possible in the future to perform major surgery without any kind of adjunctive therapy? Do you think this is an ambition for the future? This is realistic, yes, or totally? No, because that would be great. If we could have agent that could help us managing these very difficult scenarios without having to add anything, replacement on the... Maria Elisa, any thoughts about this?
I think this is, of course, an hope. And I do think from the limited experience that we have that this is maybe doable with those agents you mentioned. So I think we need experience, but all the prerequisites are there to achieve exactly what you're mentioning.
That would be great. So I think these are, in my view, very nice perspective for the future. So we are now at the end of this podcast. So I would like to thank both of you for your great contribution, addressing multiple aspects. I think we covered, in my view, what's really important to manage efficiently these patients with inhibitor undergoing surgery. So I hope that this podcast was useful for you. And do not forget to visit our web platform with plenty of education material and these great slides that you produce that are available and that we hope contribute to education and better knowledge of hemophilia. So Maria Elisa, thank you to you. Yesim, thank you to you, and hope to see you soon. Bye-bye.